It began in 1979, and every 7 years they publish an update. The number 5 edition was scheduled for last year, 2014, but there was no new Bible. The field of neuropathology is changing so rapidly, they are not able to keep up with the updates, which are occurring almost on a weekly basis. So they held a conference in Haarlem in the Netherlands last May, and they called the conference Who's Next? This is their colloquium to guide next step in developing the brain tumor classification and grading. What we have here is the photograph of the participants, and you notice it is taken in a church. Perhaps significant because maybe we can call these the high priest and the high priestesses of neuropathology. The primary focus is now going to be not the phenotype or the microscopic appearance of brain tumors, but the primary focus is going to be on the molecular information, the genotype. So it is a seismic earthquake shift in neuropathology. So here is the format they propose. Layer 1 is the integrated diagnosis that incorporates all of the tissue-based information. The importance of this is for stratifying patients for tumor treatment. And that is particularly important with other types of tumors like medulloblastomas and gliomas. So let us talk medulloblastoma. This is perhaps the best known tumor. Well, what about this one? Oh, this one looks like a really bad glioma. We all know butterfly glioma, corpus callosum. Aha, this one looks like it should IDH1 negative, wild type, and MGMT negative. So how good are we with glioblastomas? Well, pretty good, but not perfect. It means that the surgeons are still going to need to have tissue and still going to need to have genetic analysis. Now we'll close with a little about low-grade gliomas. The old was that there were 6 phenotypically recognized low-grade gliomas, grade 2 and 3 for diffusely infiltrating astrocytoma, 2 for oligodendroglioma, and 2 for the mixed oligoastrocytoma. Now, low-grade gliomas, meaning anything other than a glioblastoma, is going to be defined by simply 3 molecular subtypes. So basically, we're still going to tell the neurosurgeons where it is and what we think it is. The neurosurgeons are going to depend on us. We're going to tell them the best we can about our surrogate markers for the classification, but know that they are imperfect, and it's still going to take not just tissue under the microscope, but tissue with genomic analysis to stratify and have patients layered for their treatment. Thank you very much.
Professor Osborn, how are neurodiagnostics changing?
Neurodiagnostics are changing very rapidly because what we're trying to do now is to say if it is the genomics of a tumor that are the most important for stratifying patients for risk and for treatment, are there preoperative things that we can do to perhaps predict whether a tumor will have the certain favorable genetic mutations or unfavorable genetic mutations. And we're very in the infancy of this in neuroradiology. There are some generic things like, for example, the location of a medulloblastoma is helpful in diagnosing a certain subgroup of them. Probably 2 of them have relatively characteristic locations. The problem is that they don't always occur in those locations, and that in the most common location of all, which is in the midline fourth ventricle, all 4 histologic types occur, and all 4 genetic subtypes occur. And so we have to say to ourselves, how good are our imaging in predicting ahead of time what the genetic mutations will be? And they are pretty good in some cases. Perhaps the most interesting one is if you have what you think is a low-grade glioma in an adult, if there are tests that will say we think it has a certain favorable genetic mutation, which is the isocitrate dehydrogenase 1 and 2, IDH, maybe if it's in a critical location, you might delay biopsy and treatment for a while if it has that mutation. Magnetics MR spectroscopy has been used experimentally. It's very difficult to do, but there have been some preliminary indications that you may be able to detect the product of that mutation, which is 2HG, a particular 2HG type on MRS. The problem is that there are two types of the gene product, and they're both mixed in the spectral analysis. And so will that be helpful? Maybe so. If it's IDH1 positive and it's in a favorable location, the prognosis is going to be better. And if we can tell that, say ahead of time, we think that based on the imaging, that's what this tumor is, and it has the favorable mutation, then maybe the treatment will change. Maybe no treatment for a while will actually be the best way to deal with these patients. But it's very early infancy. Everybody's very excited about it. It's probably the most exciting area in neuroradiology right now is, can radiogenomics predict tumor behavior?